postgraduates. And special thanks to Kala for inviting me, and it's indeed an honor to be here among the stalwarts of ophthalmology. Looking forward to have my perspective on how the anterior segment OCT has helped me build my practice as a cornea and refractive surgeon at AS-OCT Hospital. So as you all know, slit lamp is definitely an invaluable tool in our practice. But when we have an opacity like this, we literally feel like diving into the cornea and see what's waiting for us inside. But that's actually an insight which the slit lamp can't fulfill. That's exactly where the role of anterior segment OCT comes in. So what is anterior segment OCT? It is giving us a high resolution, rapid, clear image of all the structures of the anterior segment, right from the tear film all the way up to the crystalline lens. The concept was, or the introduction of AS-OCT came in 1980, and the importance in its resolution has been discussed right from 1994. Going on to the different types or the evolution of anterior segment OCT, as you can see, it started with the time domain OCT. Then we were all discussing about the Fourier domain, which were further divided into spectral domain and the source OCTs. So about the time domain, it talked about a moving mirror and about a longer wavelength. The problem with the moving mirror was it was slower. The longer wavelength, however, helped us for a deeper penetration. And the spectral domain, it removed the moving mirror from there and made it faster. But the shorter wavelength made it lesser penetrating. So the advantages of fastness and deeper penetration were both combined, and that is source OCT, and that is the talk of the town now. Coming over, this is the slide for the postgraduates. It mainly discusses, when you have an essay on anterior segment OCT, make sure you have these terminologies like the low coherence interferometry, temporal coherence, spatial coherence, the time delay, the wavelength, and the moving mirror being mentioned in your essay. This diagram actually illustrates how the anterior segment OCT has its application in my practice. That is maximum for the corneal evaluations. But if this is a glaucoma surgeon's image illustration, it will be the other way around. In cornea, I use it for many of the confusions that I have, just like the photo I had shown earlier, for my clinical evaluations. Also post-graft if I have any confusions, as well as the evaluation of the ankle. As you can see, it gives us a high resolution imaging of the anterior segments in deep resolution, that is right from the decimals all the way up to the sclerals, where we can evaluate it. The glaucoma surgeon actually evaluates the various metrics of the ankle in the terminologies of AOD, ARA, TISA, TIA, right from the scleral spur all the way along up to the 500 microns as well as the 750 microns in an AS-OCT. Here the 500 microns is taken to be more significant. The parameters of AOD is mainly assessing the distance, and the ARA calculates the area. TISA is also about the area, and TIA about the ankle, in which TISA is the most clinically relevant one. Here AOD and TIA is actually describing how open the angle looks, but it's actually the TISA that tells us how well the angle is functioning. So TISA is the trabecular iris space area, and the others are angle open distance, angle recess area, and the trabecular iris angle. Going on to the other uses in the angle, pupillary block, we can assess the iris configuration, the forward bowing of the iris, and the iridolendicular block, which has its application in the acute angle closures, uveitic pupillary blocks, and the postoperative blocks. The other uses would be assessing the plateau iris configuration, assessing the post-glaucoma surgeries by the glaucoma surgeon, application in the post-operative complications like malignant glaucoma, ciliary body rotations, secondary angle closures, as well as lens-induced causes for glaucoma like phacomorphic glaucoma, intumescent cataracts, the causes behind that angle closure. Coming over to the crystalline lens application, We have it mainly useful in the posterior polar cataracts like this. Why? In order to assess the continuity of the posterior capsule. That is where the arrows, whether the capsule is continuously progressing all along to differentiate it from an adherent plaque. If it's a continuous, I'm rest assured we can have a good surgery coming over. But if you have a posterior capsule like this, then I have to decide upon removing the hydrodissection from my step. I can do a safe hydrodelineation. There are various steps to manage a posterior polar cataract. We will have to anticipate a PCR and have a backup plan for the IOL. The other reasons would be an anterior capsular fibrosis. While doing the capsular rhexis in a fibrosis, it's a little difficult. So we have to plan whether to go around with a routine capsulotomy or the other scissor methods. Then we have to assess the intralenticular dynamics in an intumescent cataract and anticipate or prevent an argentinian plaque if required. Going on, if you have a weakness of the zonule, we have to plan whether to use a CTR or Sionis. Post-operatively as well, if there is a capsular block syndrome and what is the relationship between the IOL can be assessed very well with the anterior segment OCT. Coming over to the main area, that is the cornea. If you have a case of a corneal edema, then we will have to rule out between a Descemet's membrane detachment. Which category does it belong to? Is it a planar one or is it a non-planar? If this DM has all scrolled up, will actually vary upon my plan of action in managing these cases. If it's an elevation in the interior ocular pressure, the hyperreflective will be more in the epithelial area. The anterior part will be more hyperreflective. And here I just have to manage it by lowering the intraocular pressure by giving the agents for it. Next would be if you have a complete endothelial decompensation, again the AS-OCT tells me it is a complete hyperreflectivity and my management plan will have to go accordingly. If it's a post-surgical confusion, again an AS-OCT tells me how to go about with the management, whether it's a DALC or a DMAC being done. This is an algorithm. And about corneal dystrophies, again depending upon where the dystrophy is. Let's say if it's a Rees-Buckler's dystrophy and it's limited to the epithelium and we can see the band in the anterior area and we can just do a PTK and manage it. But if it's a stromal dystrophies like granular, lattice or macular, depending upon its area of involvement, granular is usually superficial. Granular can be managed by doing a PTK and a DALC. The lattice may have to go deeper. And macular, as you all know, it's a complete corneal involvement and we'll have to do a PK here. Keratoconus doesn't have much of an application with regard to an AS-OCT. Usually it is the topography we take, but we can actually confirm our findings and plan accordingly. There is also recent taking up of keratoconus patient with laser ablations. You must have heard the terminologies like topo-guided custom ablation treatments and TREC. These are in the go now. So here AS-OCT has a role. But of late, there is very much importance in assessing the epithelial thickness, that is with an MS39, which can tell us about a formafrustic keratoconus that is just building up, which is an early keratoconus, which will be very useful for the refractive surgeons per se. But where I use my AS-OCT would be mainly when I'm planning a DALC in a patient. It will help me to decide on how much turns have to be gone in to have a good deep penetration so that I can have a good air bubble for my DALC surgery. So here if you take the thickness of the cornea to be 540, I may take around 80% of it, so it's 432. Then I divide it by 60. 60 means every quarter turns in the balanced refined cuts 60. So I divide the 432 by 60, which tells me 7. That means I have to turn or I have to make 7 quarter turns to my balance refine so that I can have a good depth and then proceed on with my DALC steps. As you can see, if the superficial scars, we can just go about with the PTK. As the scar goes deeper, we'll have to plan accordingly. Keratoplasty, again, if I have a patient who's not meeting up my clinical findings, then I can do a AS-OCT and decide whether to any further management with the graft is required. As as a refractive surgeon, I don't mainly use it for the LASIK cases, though we can use it for assessing the flap. I don't do SMILE, so I haven't started doing SMILE so far. We can be used in SMILE. We can also assess the residual stromal bed, and if we have a complication, just to confirm our diagnosis, we can rule out a DLK if required. Where I mainly use it as a refractive surgeon is in assessing the volt in a post-ICL patient. So what is the volt? Volt is the gap between the ICL I have implanted and the crystalline lens. The range that we play safely with is, I want a range of volt between 250 to 750. But let's say if I have a high volt, that is if it is more than 750, like in this case, then I have actually implanted a bigger ICL here, which will make the angle of the patient narrower. That would make me assess the IOP of the patients more often. If it is building up, I will have to go for an exchange. The other way around, if I have implanted a smaller ICL, I will have a smaller volt. Here it is 66. That will be just touching the crystalline lens, which might develop a cataract later on. So assess the patient accordingly and decide. It has its application in infectious keratitis, also in perforations and descemetocele, and also in assessing the ocular surface lesions. With that, I rest my case.